November 7th, 2019, and I'm Dr. Deuk Machen, CEO and founder of Deuk Spine Institute. And if you're watching today, you are most likely watching a live stream. We're live streaming spine surgery. We do this for all of our surgeries at Deuk Spine Institute, usually on Tuesdays and Thursdays. As long as we have cases to do, we live stream around the world so that you can watch and learn, ask questions, and be part of the surgery. Now, these surgeries that you're watching are real-time, live surgeries. None of them are pre-recorded. None of them are edited. Most of my colleagues think I'm crazy to broadcast live spine surgery, and they're probably right. But you know what? I want the world to see that spine surgery can be done well, without complication, and it can be successful. The last surgery we just did, he just left. He went home. He's doing fantastic. His back pain from before surgery is gone. He just went to the bathroom. I just saw him out. So, another miracle of modern medicine. Deuk Spine Institute's the only place in the world you're going to find the Deuk laser disc repair. That's the endoscopic surgery that we perform here with a 95% resolution of preoperative back pain and leg symptoms, as well as neck pain and arm pain if you're having it done on your neck. We also do outpatient spinal fusions, interventional pain management, and anything that is going to help a patient overcome their pain and get on with their life, we do here, as long as it's safe and reasonable. So this morning we did a posterior cervical laminectomy and fusion. Then we did a Deuk laser disc repair, endoscopic transforaminal disc repair, L34, L45, L5S1. That patient just went home. So did the posterior cervical earlier today. And we're on our last case for the day, which is a 2-level L45, L5S1 left approach or left side, Deuk laser disc repair, endoscopic annular debridement, discectomy, and our patient is awake. Are you ready to have your surgery? All right. This is Dr. Deuk Machen. I'm back here behind you. I'm going to touch your back with my hand, okay? All right. So we're going to get started. And you have a very nice back. Did I ever tell you that? Yeah. You do. So I'm going to get started, but the first thing you're going to feel is going to be a little stick and burn, okay? That's perfectly normal. Like normal isn't expected. It's basically some pain medicine I'm putting in your skin, okay? I'm going to try to make it as comfortable as possible, but I've tried all these different tricks and nothing seems to work. So I'm just going to tell you, you're going to feel a little stick and burn. And that's perfectly normal for this stage of the surgery. Yeah. Huh?
And squeeze my hand.
Yeah. If you want to squeeze anyone's hand, you've got the anesthesiologist right next to you.
Is there a good-looking guy here?
8 milliliters. Is there a good-looking guy?
Dr. Deuk.
Luis is here.
Michael.
Well, Luis.
Oh, Michael, you can.
I'm not going to say who's good-looking. I'll let the girls decide. All right. It depends on what you like. You like Latin men? You like Irish Irish guys?
Oh, Indian.
Yeah, Dr. Patel is close by. Okay, folks. So we have our view here. It's a little zoomed out. I like it a little more magged in. And L5S1 is, of course, collapsed. But there's no pseudodisc, and I can see 5-1. Let's see if we can get the end plate of 5 a little bit better. It's a little grainy. Is there anywhere, are you pulsing?
Yes, sir.
Can we not pulse? And we need to drop the table a little bit.
Okay.
1 inch. Good. Let's see that. All right. Let's open the front of the collimator.
32 star.
That's good. Shot. All right. We're definitely going to need to wag a little bit. thinking, yeah, that's a good guess. Remember, only about 3 degrees. You don't want to do more than 3 degrees. Shot? All right, I can't really tell. Let's go back. I think we either overshot it or we went the wrong way. So, shot right there. That's close. I still think we're way too grainy. Are you pulsing?
I just took the pulsing off.
You did. Why don't we go north just a slight amount with the fluoro, like 1 inch. Let's see what we got there. That's not terribly bad. I think we need to bring the table up 1/2 inch.
Okay, table up, half.
That's good. Let's get another shot. All right. Monica, any advice here?
No, that's why I came in.
This is a tough one.
Yeah.
I think you need to, I mean, I can't really tell where those pedicle is. Why don't you release the wag and let me play with it? Shot? Shot? So that's the opposite. Shot? That may be the best we can do. Let me see, hold on. That certainly pulls the iliac crest together. Shot? I'm going to have to go with that view right there. Lock it in. It's not great, but it's probably the best we're going to get. All right, ma'am. So here's the deal. I'm going to get started, okay? And I need you to just lay still for me. If you feel any discomfort, say ouch. But don't try to get off the table and help me. Just lay still. I'll take care of any discomfort. And I just need you to lay still, okay? Remember, any pain, you say ouch if it bothers you, and I will take care of it to the best of my ability. Did you know you're going to be awake for the beginning?
By explanation.
Shot? Oh, yeah? Shot? Well, hopefully it'll be quick. But I'll be honest with you, that really depends on you and your anatomy. Shot? Okay, fair enough. Monica, I'm just not getting a good enough view of that disc space. I think we need to mag it in somehow. It's too far away. Shot? That may be a little better. Are you comfortable, ma'am? As comfortable as you can get, right? Where do you feel that? Shot? Where do you feel that? Where? But not down your leg. How far down? Huh?
How far down? Is it going below your leg?
Is it going below your knee or not? Let's get an AP. So AP is a front to back view. Is it better now?
Is it better now, Elizabeth? Oh, sorry. There's a lot of noise going on. Okay, sweetie, sorry.
Is it better at all or not? You feel it in your back or in your leg? The leg is what? Well, you have the squeezers on your leg, right? That's my hand touching your leg. Where do you feel that? How far down? Any better? Let's go back to a lateral view, please. Well, this is why I need your help in the beginning. You're doing a great job. of helping me. Let me know when you're ready. Shot? That's better. Alright, are we really that far off with the iliac crest? Let's release it again, the wag. Shot? Shot? That's a lot better right there. Right there, shot? Kind of like that view. Lock it in. I'm really low in the foramen. Shot? You feel anything? Where? Your buttock? But not your leg. Shot? Shot? Well, you didn't make it easy for me, that's for sure. But we did it. We got the hard one done first, as I always do. Are you comfortable? We're going to have you to sleep very soon, okay? You're doing really, really good. I know you have a high pain tolerance. Are you? I can't remember. Are you German or Polish? German. That's right, we spoke. You remember I told you where I was born, right? All right. Bremerhaven. Up north. All right. So we're in the first disc, and now I've got to get the second one. And she's definitely not making it easy for me. Part of the problem is we're overexposed. It may be related to some osteoporosis. Do you have osteoporosis? You do, huh? You don't? Well, you don't know, or were you tested for it? Your doctor tested you, your primary care doc? Shot. Well, guys, we need to get more like a darker picture. I can't really see that 4-5. The other way. That's probably better, but yeah. All right. That's too dark. We need to line up the end plate of inferior end plate of 4. So let's do this. Let's go north just about half an inch, and then shot. That's good. That's actually not too bad. I think it's too dark though. So let's try to lighten it up. All right. Shot. So I have to navigate to the next disc. Shot. She doing okay? Shot. Thanks. Shot. And the way I do that is I go and I find the facet joint. Shot. And then I make my way past the facet joint. Shot. She having rhizotomy or no afterwards? No. Where? Where do you got that? The buttock? How far down? To the knee? Almost to the knee. I understand. You're doing fine. Everything's okay.
She said that's where she feels, right? Is that?
Shot. Sean, did you have a question? Shot?
None yet.
Uh-huh. Well, you're a lucky lady. I was able to get to where we needed to go. So I'm going to put you to sleep in just a few minutes, okay? Now, this is the part that I hope the anesthesiologist does a really good job. Because I'm going to have to figure out if we're in the right spot.
I'm going to hold her hand. We need you to be awake, so
How bad is that on a scale of 1 to 10? Yes.
she doesn't hurt much.
I need a number.
On a 1 to 10 scale, sweetie, where do you think?
What was the worst it got to? 7. At 4, 5, 7. Is that, and that's where you get your, I'm sorry, I didn't hear.
What did you say, sweetie? Can you say again?
I understand. We're not trying to hurt you that much. We just want to make sure we're in the right spot. How bad is that on a scale of 1 to 10? How high did it go? How high did it go? How high of a pain level did it go? 8. All right. Go ahead and count from 1 to 100 in German. And when you wake up, you'll be done with your surgery. And we'll be from 1 to 100 by ones. 1, 2, 3, 4, 5, 6, 7. Come on. You know what I'm talking about. Keep going. If you get to 100, I don't pay the anesthesiologist today. All right, I need to see down lower. Come down just a little bit with the fluoro. Good. Hey, good job. You're getting better at this. All right. So, you know, with her, she has a collapsed disc at 5-1 shot. And we've got the guide wire in position. We're bringing the needle out. We're going to do everything over the guide wire in terms of the dilator and then the tubular retractor. So what I'm advancing, for those of you who are interested, is this metal tube, which is actually made in Germany, which is where she's from, and I'm originally from. And this tube actually passes over the guide wire, and it takes me right where I need to go. Safely, by the way. That's the important thing, is safely, right? So when you have a destination to get to, you want to travel safely to your destination. We take safety for granted, not us as in the surgeon, but as a society, we take safety for granted because our government normally looks out for the citizens and creates safety measures, protocols, rules, laws. Just lay still, she's responding. We're right on the painful part of her disc. And so we trust that in our day-to-day lives, we're going to be safe. And surgeons, we're actually performing an act that would normally be considered assault. We're assaulting a human being, but we're not really assaulting a human being. We're cutting them, we're sticking a piece of metal in them, but we're doing it to fix a problem, a medical problem, right? And so we surgeons, since we're doing something that normally wouldn't be done to a person in an attempt to help them, we are really have to be careful about safety because we're responsible for the safety of this patient. Yeah, she's kind of, I don't know if it's reflex, but she's not so bad now, but just a minute ago she was kind of
Yeah,
arching.
just increase.
Yeah, yeah, but she's fine now. I'm okay with her. So you don't have to go any deeper.
Yes.
So I'm coordinating with the anesthesiologist about how deep to put the patient. And neither the anesthesiologist nor me want to put her any deeper than she needs to be, so she doesn't like create a separate safety risk for herself, like falling off the table. Shot. So our goal is to work together to get this patient to a level. Is she okay?
Oh, yeah, yeah.
To a level of anesthesia where, so let me see, shot. I think I need to go down, aim down just a little bit. I need to get this guide wire out. Here you go. So at some point the guide wire can actually become a problem if it gets trapped.
Make sure it's not
Shot.
above the CR.
Okay.
It's good?
Yeah, she's watching and I'm watching and the C-arm's fine, but thank you, Luis. That's exactly what you need to be doing. All right, I've got the dilator now safely into the disc, the first disc, L5S1, through the tear. Now, for those of you who haven't seen this before, can you see this, Sean?
Yes, we can.
The whole surgery is done through this metal tube, and it's called in surgery a tubular retractor because it's retracting the skin and the muscle and the fascia. Like retracting means to push back, and it's creating a corridor, a surgical path or corridor for me to operate in. And it's tubular shaped as opposed to rectangular shaped. So it's a tubular retractor. I didn't create this. It was created by a German company, and they've done a really good job of designing these instruments, and I learned how to do the surgery using their instruments because I think that they have what I feel is the best instruments for doing the surgery. Safest, best, most effective. And if you remember from my prior broadcast, I only buy and use the safest and the best in my surgery. Shot? All right, so at this point the tubular retractor's in the disc space, and I'm going to get the dilator out because it's blocking my way. And now we have a corridor, a path, a safe path to work on the disc. Shot? So it hasn't moved. Through the tubular retractor. Yeah, I'll need that. Yeah. So unfortunately, some of the tissue deep inside at the tip has wedged itself between the dilator and the tubular retractor, and it's stuck in there. Shot? So I got to get this dilator out. And by the way, that was my little creation there that I had to improvise because this thing that is designed to grab the dilator and pull it out was slipping. So I just threw the Raytec over it, and it gave me more friction. It increased my coefficient of static friction, for those of you who are physicists, and basically allowed me to get the dilator out. All right, let's get this floor out, please. I don't know what you're taking so long for, but move it.
We have a question.
Yeah, just give me a second on the question. Do you want that in your face there? Why don't you pull it back a little bit? Jordan, pull that floor back, please. You're supposed to pull it back. All right. As I said earlier, all of our surgeries are live and recorded live and broadcasted live, so there's no editing. So everything you hear and see is in real time or recorded in real time. And if we have a problem, you're going to see the problem. If the surgery goes smoothly, you're going to see the surgery go smoothly, which I pray for every time. All right, so I've taken my camera and scope all the way down the tube, and there's the end. And the first thing I'm seeing is a little piece of herniation. I'm going to grab it and pull it out. Here you go. And back into the disc. The blue dye we inject with the discogram. There's a herniation. The blue dye stains the herniation, aka degenerated disc. And of course it starts leaking out as I start irrigating. So no big deal, but it's making the world seem blue to all of us. Interesting. I feel like I'm working in my choral room. Take that, laser. We're ready for the laser. It's on 30. Okay. Thank you. All right, so we're ready to get started. That's part of the herniation. And as you saw, I used the grabber, but the grabber didn't take it out. So I have to come back with a laser, a different tool. The laser is very effective. And honestly, you need both. You need the pituitary rongeur or grabber, as well as a laser. The laser is the blue fiber. You can see the end plate of L5 on the left at about 9 o'clock. There's a little bone spur. I'm zapping it with my laser fiber. Who is making that noise?
You?
Who?
You?
I didn't make a grunting noise. Is she okay?
Oh yeah, she's just snoring.
Okay, snoring. Very good. Very good. I'm sorry, did I answer the question yet, or I haven't answered it yet?
No, we still have a question.
I apologize. It's the end of the day, and my head has been hurting me all day, as I have meningitis. You like that? That's pretty funny, isn't it? We're good. I have meningitis. Did you know the most common cause of meningitis is viral meningitis? And I have viral meningitis. Gastroenteroviruses are the #1 cause of meningitis. Completely benign. Don't have to rush off to the hospital. It's self-limiting, meaning it'll go away on its own. You just need to take some Advil, rest, which I'm not doing, and drink lots of water, and give it a few days to go away. And it does. But I have people who rely on me, just like Luis does, right, Luis?
Yes, sir.
By the way, how is your family?
Very good, sir. Thank you.
Everyone's recovering well?
Yes, yeah. Thank you.
All right. We'll take that question.
Yes, one of our viewers says, I've had Cauda equina syndrome for 16 years and I'm still waiting for a cure. Have you ever run across any patients with it, and have you ever treated them?
Well, we have a viewer who says they have Cauda equina syndrome and they're waiting for a cure. Have I ever come across it? Have I ever treated it? So Cauda equina syndrome, everything okay, doctor?
Yeah.
Cauda equina, what is Cauda equina? Cauda equina. So Cauda equina is a medical term. For those of you who don't know, it's Latin. Equine means horse, cauda means tail or back end of a horse. So quite literally the tail of a horse. Cauda equina. And what it refers to is when the nerve roots, the nerves in the lower back, get pinched by something. Spinal stenosis, narrowing, something pinches them. usually a disc herniation, standby laser. And it affects people's legs, and it can affect their bowel and bladder. So they can lose control of their bowel and bladder. They can lose erectile function, so sexual, bowel and bladder, and strength and feeling in the legs. You get numbness in the perineal region where your scrotum or labia are. And basically it sucks, and it needs to be treated surgically. The type of doctors that treat Cauda equina syndrome are neurosurgeons, which I actually happen to be a neurosurgeon. So to answer our viewer's question, yes, I have treated Cauda equina syndrome. And I'm sorry that you've been dealing with it for 16 years or so. But Cauda equina syndrome is usually a surgical emergency. It's like having a gunshot wound to your body. You go to the emergency room right away and have it fixed. So why you have had it for 16 years and never had it fixed is beyond anything I could ever comprehend. But we do live in a very strange and brave new world. So I don't know why you have Cauda equina syndrome after 16 years and it hasn't been fixed, but it should have been fixed a long time ago. But yes, I'm aware of what it is, and I'm very capable of treating it. Now, I don't know why you have Cauda equina syndrome, but if you have a fixable form of Cauda equina syndrome, which you should, then you should have it treated surgically. The problem is I don't know for your case why you have Cauda equina syndrome. Is it a herniated disc? Is it bone spurs? Is it a fracture? Is it a mass like a tumor? I mean, what is it? What's causing your Cauda equina syndrome? But whatever's causing it should be taken out and fixed. All right, next question.
That same viewer actually followed up by saying she did have it surgically fixed, but because she waited too long, she now has permanent damage.
All right, well, you have a different problem then. You don't have Cauda equina syndrome, you have permanent nerve damage. That's a very different problem. Huh? But I will tell you this. Don't believe what people tell you. Get a second opinion. In other words, whoever told you you have permanent nerve damage, you may not have permanent nerve damage. I can be honestly tell you that 9 out of 10 times when patients are told they have permanent nerve damage, they don't. The surgeon just didn't do a very good job of operating. So what I would recommend is that you see me, send your MRI in if you can, let me look at it. I'll tell you if you have a fixable problem. The truth is 9 out of 10 times you do. So if I was a betting man, which I'm not, I would bet that we could fix your back and we can fix your pinched nerves and your chronic radiculopathy. I don't know that for sure, but I need a couple of things to know. Number 1, an MRI. Number 2, a CT scan. Number 3, a nerve test, EMG, nerve conduction study. And number 4, a physical exam. I need to see you and I need to examine you. If I could do those things, I could tell you for sure if you have permanent nerve damage or not. And I could give you a chance of success for the surgery. But honestly, what I've seen too many times is that people get surgery and the surgeon doesn't do a very good job. He still leaves the nerves pinched. They don't do it on purpose. They do it out of incompetence. And it's not intentional. It's just that's what they were taught to do. That's what they're accustomed to doing. That's what the kind of surgery they're comfortable doing. Unfortunately, the patient pays the price for the surgeon not being able to do the surgery properly. So, to summarize what I'm saying, we can likely help you. There's a 90% chance that we can make your problem much better. Are you pulling on it? Are you like trying to fish for something there? And the only way to know for sure is to come see me. But don't give up hope. Hope is just around the corner. You have another question?
That's all for now.
But do you have a question? Sean?
I don't believe I do.
You good, man?
All right. You see? Huh? My staff know everything. They have no questions. Yes. Who's that? The Irishman? All right. You're welcome to ask.
So when you do, if you do get a herniated disc from trauma,
I'm sorry, if you get a herniated disc from trauma,
is
stand by.
there a certain like protocol or treatment that you should do to so it doesn't get scarred, basically? Is what I'm asking.
All right, so one of our staff, somebody who has been here for a few years, is asking a very good question. If you have a traumatic injury and you get a herniated disc, is there something you should do to basically make sure that things heal right and that you don't get any permanent problems? Yes, there is. The most important thing to do with a herniated disc is to know whether or not it's causing nerve damage or spinal cord damage, because those are the two things that a herniated disc can do that are really bad. You know what I mean? So as long as your herniated disc is not causing nerve damage or spinal cord damage, and it's just causing pain, you don't have to treat it. You can live with it. And the fact of the matter is you can get it fixed sometime in the future if you need to. That's why we always try conservative treatment for patients that only have pain and they have no neurological deficit. It's a very reasonable treatment option. Just leave it alone and take anti-inflammatories, give your body a chance to heal it, do some physiotherapy, do some, behavioral modification for a few months, try to let it heal on its own and get rid of the pain on its own. Let the inflammation burn out. But the problem is if you do have a neurological damage and a compressed nerve or spinal cord, then it should be fixed right away. And Cauda equina syndrome, like that patient asked, is an emergency to fix. You have to fix it that day, surgically. And the longer you wait, the less likely it's going to get better. But the most important thing, and I didn't mention this if the person's still listening, is if your leg symptoms change with position, change throughout the day, they get worse with certain activities, better with others, that's a very good sign that we can fix your leg problem. If your leg symptoms don't ever change, they're the same whether you're walking, standing, bending, twisting, lying down, it's always the same, never changes, not one bit in terms of the pain or the weakness or the numbness. If it never changes, then that's a bad sign that the nerve is permanently damaged. But again, it's something that I can figure out usually by interviewing the patient, examining the patient, and looking at their diagnostic tests. But I would bet that this patient that's talking about Cauda equina, I would bet that they can be fixed. They just need the right surgeon and the right surgery. Great questions. All right. Any more questions from our audience? This is really the time to ask, folks.
Not yet.
Very good. So I'm Dr. Ara Deuk. I'm a neurosurgeon, board certified. I've been doing neurosurgery for 22 years. The Deuk Spine Institute is basically the leader in the world in advanced spine surgery for degenerative conditions. We're a leader of the world in endoscopic surgery. And when I say leader, I don't mean we do the most surgeries. I mean we have the best outcomes. We have the best results, the safest and best results in the world. In other words, we get rid of more pain with our procedure than any other surgeon and any other procedure. And we've had 0 complications in 1,000 surgeries, so you can't beat that. You may equal it, but you can't beat it. So I hate to say it, and I don't mean to sound arrogant, and certainly not trying to be arrogant, but we are unbeatable with our results. And it's absolutely true. Now, it doesn't mean that somebody else can't have the same results. Any surgeon that uses the same techniques, diagnostic algorithms, and treatment modalities that we do can have the same results. There's nothing magical about what we do. It's anyone can do it. You just have to know what you're doing, and you have to execute it properly. And there's very few places in the world that can do that. Why do I say that? Because it's true, and because for the people out there looking for a solution to their problem, I want people to understand that. I don't want people to think they can go anywhere and get the same surgery wherever they go. You can't. The surgery, the surgeon, the team, the facility, the equipment, all of those variables are not equal and not the same in any two places in the world. Even if you asked me to create another Deuk Spine Institute in another location today, it would not be exactly the same. Of course, it would be slightly better, but it would not be the same as what we have here. For obvious reasons. Some of the equipment we can't get anymore because it's a little bit older, so we have to get newer equipment. But our equipment is still within a year of being released, basically. So we have the latest, for example, latest laser. We just bought it. This is like the third week we've had this laser. All right, we're done with this disc. So we have the latest laser available, the latest Homium YAG laser from Luminous. Laser off.
Lights on, please.
But this camera right here that I'm using, though it works perfectly well, there may be a newer camera available. So even if I try to recreate a Deuk Spine Institute somewhere else, I couldn't do it exactly the same. But I know I could do it so that the results are exactly the same. All right, I need a grabber.
Did he suck in water there or no? Can you check? Because I feel
What is it, Luis? What's wrong?
No, I just want to make sure that it's good.
Looking good. All right, that was our first disc, and we're going to do the next disc, and we'll be done. So hold on with the fluoro. I'm going to take this tube out from L5S1. I'm going to give it back to Luis, and I'm going to apply pressure to the paraspinous muscles while the fluoro comes in. And I'm applying pressure to the muscles because we didn't damage the muscle, but we did spread the muscle open. And sometimes when you do that, you might tear a little vein. You won't tear an artery, but you might tear a little vein. And those veins can bleed. They don't bleed much, but you don't want any bleeding if you can avoid it. So you apply pressure, and that stops the bleeding. Let's go. What are we waiting for, my friend? You're going to do an AP first? All right. I'm fine with that. How are we doing, Luis? Are we okay to use that guide wire? Yeah? Nice. All right, so we've done one disc and we're getting ready to do the second one. Our patient is asleep at this point, having nice dreams. Shot. Let's go lateral, please. Just go lateral. I did say okay to the AP view, but we don't need the AP view. Let me apply some pressure here.
Make sure this suction is going to be on the other side, north of the C-arm, please.
What's the problem?
No, I like this too, north.
Yeah, I love it. You're starting to micromanage all the details. Let's just give me a second. Are you taking a fluoro shot? All right. Let's just keep. Shot. So, why does it look like the table went down a little bit? Did it? No? Let's bring the table up slightly. Maybe just an inch. That's enough. Let's see. Yeah, let's see where we are there. That's better. Yeah, I like that. All right, so I'm taking the needle out. I'm going to leave the guide wire in. Shot. Good, very good. And we're going to go fix L45 next. Shot. I will say, if you do this type of surgery, this transforaminal endoscopic surgery, as a surgeon, you have to be careful in patients with osteoporosis or osteopenia because you can fracture their bone pretty easily. I mean, if you think about it, you're putting this very rigid piece of metal in to a disc space that is pretty non-compliant. It doesn't want to move. And so the bone won't move out of the way necessarily. The disc space won't open. And as a result of that, you could end up fracturing an end plate. You really don't want to do that if you can avoid it. Shot. All right. So we're coming up on 4-5 now. Shot. Okay. Very good. Let's get pressure on the midline. Shot. Shot. That's looking better. Shot. Uh-huh. Shot. Oh, so nice. Thank you. I like when you keep her deep enough that she doesn't tighten her muscles up, because once the patients start tightening the muscles up, it just gets very hard to, get into the disc space. All right, tubular retractor. So your level of anesthesia is perfect for me. Hopefully it's good for you. That's good to hear. All right, I need the impactor. She okay?
I'm watching her like a hawk.
I'm sure you are. Shot. So we're advancing the tubular retractor through the foramen. Shot into the disc space. Over the dilator. And again, it's stuck, but that's okay. We're prepared. Shot. It's always good to be prepared. Right, Luis?
Yes.
Flow out. Thank you. At this point, we don't need the fluoro machine anymore, so you can pull it out. And we are just about done with this surgery. I need about 10 more minutes. 10 minutes, doctor?
Sco blanc.
Anyone ever see Spies Like Us? Luis, did you see that movie? Doctor?
Yes.
Doctor? Doctor?
No, actually, he's the one who's doing the appendix, right?
Yeah, the appendix surgery. Remember that?
And then they said, he's so scared, he said, conquer or he runs. That was,
That's a good movie, huh?
oh, who is it then? The famous.
It was Dan Aykroyd
Yes.
and
Spies like us.
Chevy Chase. Oh, yeah.
Especially the part where they asked them to do the surgery.
Yeah. Unlike the mullah's son or something, or the tribal leader's son. Okay. We are ready to bring the laser in. So that's our annular tear right there. We're going to clean up with the laser. This is how we get rid of the back pain. letting all my secrets out of the bag now. Next thing you know, Dr. Kalkarni is going to set up a spine
Center.
endoscopic spine center in Nepal at Everest Base Camp.
I know.
Right? Come get your back fixed and climb Everest.
Exactly. Don't worry, it's a double fix.
Double fix. Take.
So now, wall front, whatever, those, they don't need, of course, the trauma care. I'm thinking, what other situations or locations this sort of surgery is most helpful.
What are you saying?
No, I'm thinking about besides outpatient,
Yeah.
what other locations that this could be used effectively, quickly, that
I mean, you know how many people have herniated disc surgery in the world every year? Millions.
millions, you're right.
And all those millions of people should have this surgery instead of a microdiscectomy, laminectomy, fusion, artificial disc. This is better than all those surgeries for this herniated disc that's symptomatic. The problem is, I can't do it alone. I'm just one person. You need somebody big to promote, and there's a battle ahead, you know, with the implant companies and with the insurance companies. They don't want to pay for it. So another piece of herniation coming out nicely. Doing a little Deuk laser disc repair dance.
So I'm looking into this ECHO GEO, voluntary service in for big cat in Kenya.
Yeah.
So you can
It's a tour group.
what's that?
It's a tour group.
It's actually a voluntary organization.
Really? And you get to work with big cats?
Well, it's not work, but you have to go around and count
Count them.
count them. So I
It's
think
better than working at Walmart.
no better than cleaning their excreta. So
Why would you ever clean their excreta?
well,
They're out in the safari. They're out in
no,
the
Rina, I mean, you're
on the
right.
plane.
You're right. You're so smart. I meant volunteering in sanctuaries. Over there, you go like elephant sanctuary. So anyway, they don't charge much.
Charge?
For 2 weeks.
You have to pay to go there and count
Of course.
lions?
Well, of course.
Seems like they should be paying you,
No,
if anything.
this particular one that I want to go
Yeah.
is counting the you go on like a safari, right? But your focus is to count the number of big cats, lions, not
Cheetahs.
tag them, just count them and see in that particular area how much there are. And then you have a tent, which is fairly, we pay $700 per day. Tent, which is, but
Okay. Do you hear yourself?
That's one of the nice tents that has.
You're saying you're going to be counting lions and sleeping in a tent.
no,
I don't know about you, but I don't think a tent's going to give you enough protection against a lion
no,
if he decides to eat you.
no, this is not in the area where the lions have been trapped.
Right.
This is hopefully, I've stayed around in the national park, Chobe.
Uh-huh.
So
I'm just having fun with you.
so anyway, so for 4 weeks,
Uh-huh.
it's 2,000 something for no, 3,000 for 2 weeks. So I'm thinking about going 4 weeks, so I get to see as many as I can.
Who has a phone?
Huh?
You should. Go 4 weeks.
That's what I'm doing.
You think you can handle 4 weeks in the African
I've
plains?
I went this time, remember? A
Yeah.
month.
Yeah, but that was because you were climbing a mountain.
Then I did safari for 11 days.
I know, but see, you're doing something every day, like something interesting, different.
But this is so interesting, looking for tracking the lions and big cats.
Okay. For a month? I mean, I could do it for a week,
Well,
and then I would be
because,
bored.
see, this is the thing. You can do this surgery 10 per day, right?
I don't know. Maybe not. I don't think so.
But you're so passionate. If worse comes to worse, you'll do it.
I mean, if I get 10 per day, I'm going to train Dr. Patel how to do it. Let him do them. As long as they're getting done right. You know, I trust Dr. Patel.
So I'm surprised that you haven't been able to find someone just like you.
Well, there's not enough business to hire somebody like me.
No, I mean train.
There's not enough business.
Okay.
You have to have the patient volume, right? I don't have the patient volume yet.
Correct.
I'm very selective on who I operate on.
Correct.
I don't operate on everybody that wants to come here.
See that? Thank you.
Yeah, we don't operate on 9 out of 10 patients.
Tom, Dick, and Harry will not operate.
Well, we try to fix people without surgery. So the ones that you're seeing having surgery,
Comorbidities and all those things I really like because it makes our job.
all right, can you look up on the internet somebody? I think it's called The Ghost and Darkness or something like that. And Darkness? It's a movie. It's an old movie about lions in Africa hunting and killing the tribes people. Ghost in the Darkness, I think is what it's called. It's a really good movie. It's with Val Kilmer, I think, and Michael Douglas. Yeah, but I can't tell you anything more. It's in Africa, and you would like it, except the humans win.
See, I used to
Ghost in the Darkness, I think is what it's called. The Ghost in the Darkness. Can you see if that's the name of it? It's something like that.
That is what it's called. I looked it up.
The Ghost in the Darkness?
Yes.
All right, cool movie if you like cats.
okay.
It's very interesting.
I will buy one from Amazon.
It's an old movie. It's like from the 80s.
That's okay.
Like probably like 87 or something like that. 86.
I thought you would get it for $3, right?
Yeah, $3.
$3.
I like old movies. I don't like the newer movies that much. I don't mean like black and white movies. I mean like 80s, 90s. The movies were done really well.
There are a couple of new ones that come up. Alec Baldwin, anybody knows the name? It's a
Alec Baldwin. You like Alec Baldwin?
huh?
You like Alec Baldwin?
No, one of the actors, but there are quite a few.
Do you like Alec Baldwin?
I think so. He's a great actor.
Do you like comedy?
I like comedy, romance, mystery.
Do you like comedy though?
Yeah.
Like what is it called? Bali.
I like Steve Martin.
You like Steve Martin. I like Steve Martin.
Oh, he's terrific.
Oh yeah.
Alec Baldwin is very comedian like.
If you like comedy, there's a movie that I love. It's called Fun with Dick and Jane, and it has Alec Baldwin in it. Fun with Dick and Jane.
Oh, yes. Okay.
Have you seen it?
I've heard, but
Have you seen it, Luis?
Yes, with Jim Carrey.
Yeah, with Jim Carrey.
Yeah, it's good. It's good.
It is the funniest damn movie.
Kitty for me is too much.
Oh, really?
I
No, no, you would love this movie.
okay.
You would love this movie. There's a herniation, by the way. There's still a piece down there. It is literally one of the funniest movies I've ever seen. What scene are you thinking about?
Indicted.
The toilet?
No, I said, what is it, indicted? He just, he started running. He was, when they start capturing everybody from the
Oh,
country.
all the Hispanics?
Yeah.
Yeah, yeah, yeah.
Oh, yeah.
That's
He
the
was,
funniest
yeah,
scene.
Yeah.
He's like, really? I'm an American.
Yeah.
Really? Yes. call my house. And remember his son? Hola! Get in the bus.
Okay, sweetie, I'm done. Just relax. Go to sleep. You want her to sleep a little longer?
Just a few minutes, but not deep. I mean, we're almost done. I'd say we need 3 minutes. I'm just
Okay, sweetie, fine.
working on this herniation here,
Okay, you can.
and it's
You have a little tape across your.
We have a question.
sure.
Is all of the blue fluffy stuff herniation or
Yeah.
inflammation?
No, the blue stuff is herniated disc. Herniated disc. It's nucleus pulposus. And the inflammation is going to be, chronic inflammation is going to look like scar tissue. It's white. And that's some of it right there at 12 o'clock. But the granulation tissue is pink. And we don't see a lot of that right now. It's kind of hard to see. It's usually very small nests, you know, little clusters of it hidden away in here. Almost done.
I like Nat Geo Wild.
What is it?
Nat Geo Wild.
Oh, Nat Geo?
Wild.
I couldn't understand the last word.
Wild. In like wild.
Wild. Say wild.
Wild.
Wah.
Wild.
Wah, wah, wah. Say wah, wah.
Wild.
Come on, pretend you have a motorcycle. Wah, 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 wah.
Wild.
Wild. There you go. I like Nat Geo Wild too.
And if you have not, and I love of course lion documentaries. There is one called Savage Kingdom.
Yeah, there's some granulation stuff there, right there, that pink stuff. All right? That's where the pain comes from. So there's one called what now?
Savage Kingdom.
Savage Kingdom.
There is this very famous lion.
Oh.
Savuti.
Huh.
Botswana.
Yeah.
Kobe. And
All right.
it's about him and his bride and his children.
Those are great programs.
Yes.
Nat Geo Wild. Listen, I'm going to tell you something I just realized about you. You know what you would really love? I think I told you this before. Scuba diving.
I can't swim,
That's right. You told me you couldn't swim.
but how can I scuba dive?
Scuba diving. Learn how to swim. Then you get to see the lion of the ocean,
Oh,
the orca.
well, I'm not much into fish.
Oh.
But actually, you know what? We went to Pacific Coast years ago,
Uh-huh.
and we saw a bear.
Yeah. But you get to see sharks. You get to see, I mean, you like all this African wild stuff, right? Well, all of it started in the ocean, in the reefs. So
He's right. It's the best thing you ever do.
it's amazing, isn't it?
So relaxing.
It's so relaxing. I love scuba diving.
So now you must have been to Cozumel, right?
Cozumel, yes.
For
Why?
scuba diving?
Why do you say must have?
Well,
Cozumel has one thing and one thing only. It's called drift diving. It's world famous for drift diving. That's why any people go to Cozumel. Right there, some inflammatory tissue. Who was asking about that? That's that pinkish stuff right there. Then she's moving because it hurts because we're right in the painful area of the disc.
I feel like you're going to the water like 20 miles.
We have another question.
Yes, we have a question from our viewer.
Yes, one viewer wonders, can this procedure be done on a thoracic herniation?
Can this procedure be done on a thoracic herniation? No. But I bet you don't need anything more than a rhizotomy. For the person who asked, can this procedure be done on thoracic? It cannot. The reason it cannot is because of the rib head. The ribs get in the way, and it can't do it safely. 30 seconds. Yeah, of course.
Dr. Deuk, you ever done any diving in Cozumel or brain cayman or anything?
Oh yeah, of course. I dove Cozumel. Blue parrotfish. It's the only place in the world you're going to find a blue parrotfish. Standby laser. I'm a very big diver. I've been open water diving now since I was 17. And I'm 48, so
Patty or Allie or what's your
I'm PADI advanced. Yeah. All my kids are PADI advanced. My wife is PADI advanced. Advanced open water.
I just did my rescue diver about a year
Oh, nice. I almost did rescue diver, but I just couldn't spend the time playing with oxygen tanks and, you know, I'd rather dive.
So you don't have to know how to swim with scuba diving, right? Or you do?
Well, you float, but I mean, you really can't swim at all,
Noodle, right?
huh?
Swim with a noodle,
You can't scuba dive with a noodle
no?
unless you want to get eaten by a shark. But I'm just saying you would love it down there because there's a whole world down there. It's more interesting even than an African safari. Oh yeah.
He's gonna convince me.
That's okay. If you ever try it, you'll see.
Okay.
And if scuba diving ever gets boring, you can go on a night dive.
So now there is an Australian, what is that, reef?
Yeah, the Great Barrier Reef.
Yeah. You've been there too?
I have not been to Australia, no. No, I would love to go someday. I'm waiting for an invitation.
You should
So
come.
you need a patient for surgery in Australia.
No, I'm waiting for the Marine Society to invite me to come speak about the parasite that I found that's killing all the reefs in Australia, killing all the coral, that I actually discovered last year is the cause of all the coral dying around the world. I'm waiting for them to figure out I'm right and to invite me to come speak. And then I'll go to Australia. But I think I would just be too depressed seeing all the dead coral, you know?
We have another question.
Yes.
If the patient is asleep during the surgery, why do they respond to certain stimuli?
Great question. When you're sleeping at night, why do you respond to certain stimuli? Right? So sometimes you're deep asleep and you won't hear the television in the other room or the phone ring. Other times you're sleeping lighter. The fact of the matter is that we don't want the patients deep asleep. The deeper the patient is asleep, stand by laser, then the more likely they're going to stop breathing. And a patient who stops breathing can die very quickly. So the anesthesiologist has a tough job. She has to balance the patient being asleep enough so they don't feel anything and don't remember the surgery, yet awake enough to protect their own airway so that they don't vomit, aspirate, and die. But very good question. All right, there's the nerve right there. You all see that? We're at 11 o'clock. There's the herniation gone.
Lights on, please.
We are done. I will be happy to take more questions. If you've got them, type them up. This is the time to ask them.
Hold it like
Scope
this.
off. Another successful Deuk laser disc repair. You ready? Let me put this. I'm going to show you folks the size of the incision as soon as I get this tube out. So I'm going to put a little bit of pressure here because remember I told you if we tore any of the veins, we don't need to put a lot of pressure, just enough to keep the blood in the vein while the vein seals itself. Did you know that your veins and arteries can seal themselves? Yep. The way you do it is with something called a platelet plug followed by a clot. The platelet plug is actually platelets that come in and see a tear in the blood vessel wall. They actually see your tunica adventitia, which is the connective tissue outside the endothelium. And that tunica adventitia stimulates a platelet plug to form, which is why we don't do surgery on patients who are on antiplatelet treatments like aspirin or Plavix, because they won't form a platelet plug. If you don't form a platelet plug, you're not going to stop bleeding. You just keep bleeding and bleeding and bleeding, and that's bad. So we want our patients to have normal hemostasis or coagulation during surgery. So we have to make sure our patients are not on antiplatelet drugs like baby aspirin, regular aspirin, anti-inflammatories, or prescribed antiplatelet like Plavix, clopidogrel, etc. And all it takes is about 3 minutes for the vein to stop bleeding with normal platelet and clotting function. Well, I hope you've enjoyed the surgery. I'm just applying pressure to the muscle with my elbow. I'm not actually taking the thinker pose. But let me show you the incision so you understand what we did. Can you see this here, Sean?
Yes, we can.
So there's a little incision, 7 millimeters, and there's the venous bleeding. Luis, I need you to apply pressure here.
Yes, sir.
Give it about 3 more minutes.
Yes, sir.
I'm going to call our EBL about 10 mils. Great job, everybody. Thank you all for sticking around and getting it done.
Are you gonna be around or you're leaving?
Me? I'll be around for a few minutes. Why? You want to talk about scuba diving?
No.
Are you trying to sneak out of there?
No, 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 he's okay.
Do you need some IV for them?
No, I just want to
I do.
negotiate.
Oh. Dr. Deuk here with you on this glorious Thursday evening, November 7th, 2019. What lies ahead? Who knows, right? But we do know that there's a question. Where did you learn about laser disc repair? Somebody's asking me, where did you learn about laser disc repair? Great question. The answer, many places, most notably overseas. I learned about endoscopic spine surgery from surgeons around the world. And there were probably 10 of them that influenced me over the last 15 years. But the ones that influenced me the most as a surgeon would be a group of Korean surgeons who taught me how to do anterior cervical endoscopic surgery. Dr. Sang-ho Lee at Woodidal Hospital in South Korea. Dr. Gun Choi, also at Woodidal Hospital, South Korea. And I also learned the lumbar procedure from them, as well as from a German surgeon, an English surgeon, but most notably a Chinese-American surgeon, Dr. Anthony Young. Dr. Young is in Phoenix, and there's more people than that, but those are the ones that I would mention. And of course, I taught myself a lot. So it's not like I went out and learned a technique from anyone. I developed a technique. That's why it's a Deuk laser disc repair. But the basics of the surgery I learned from other surgeons. So I don't know if that's what you're looking for an answer, but I think that that's what you're asking me. The Deuk laser disc repair that you just saw, about 60% of it is what I created, and 40% of it was learned. It's a fair assessment. 60-40. So you'll find that every endoscopic spine surgeon does their surgery slightly different. Endoscopic spine surgeons are pioneers. They have the personality of a pioneer. They are not timid. They are not meek. They are bold. They're willing to take some risk for a reward. Of course, the reward I'm talking about is a better outcome for their patient. The risk I'm talking about is to try something different in surgery, something they think is better. Is it experimentation? No, it's not. It's just variation. Every surgeon does their surgery with a degree of variation from each other. No one does surgery exactly the same. I've tried to make that point almost every time I've been on air. You need to understand that. Surgeons are not like cars. Spine surgeons are not like a Toyota Corolla. You can't get the same car here as you would in Boston, as you would in Los Angeles. They're all surgeons are different. The way we do surgery is different. And that's part of the reason why there's so much confusion around the world as to what the right treatment is for a condition. That's the reason why when patients go get second and third opinions, they get 2 or 3 opinions about what should be done. And those opinions can be completely different. In my opinion, what really matters is who's able to fix the patient and give them the most relief for the longest period of time with the least risk and the fastest recovery. Think about that. Just think about that for a moment. What procedure is able to give a patient the greatest amount of relief of their symptoms? So, 50%, 95%, which is better? Obviously, 95% is better. And for the longest period of time. So, whose procedure is going to give the patient relief for the longest period of time? I don't want relief that lasts a day. I don't want relief that lasts a month. I want relief that lasts a lifetime. So the Deuk laser disc repair is that relief for a lifetime. So you got to ask yourself, why would the Deuk laser disc repair procedure give patients relief for a lifetime? And part of the answer is really stability. You see, other surgeries require the surgeon to remove parts of the spine in order to get to the disc. And the parts they're removing are important parts. It's like taking the foundation out of your house and expecting it to stay standing. You can't. Once you start removing a quarter of your foundation, your house is going to start sinking. Well, the same thing happens when you remove the facet joint. If you take a facet joint out in order to get the disc herniation out, your spine is going to start sinking. And over time, it's going to create more pain, and it's going to create another herniation and stenosis, which is then in turn going to cause a pinched nerve to get worse. So, going back to what I said, which procedure gives you the greatest amount of relief for the longest period of time? Deuk laser disc repair, hands down, over any other spine surgery in the world. Now, which one is the lowest risk to the patient? In other words, I'll be honest with you. I can't tell you how many doctors come to me at the hospitals when they see me and they say, I tried sending you a patient, but you didn't take their insurance, and they didn't want to pay money. So they ended up going to another place, which I shall not mention, but they do a lot of surgery on the spine there, then they're close by, and now they're in the ICU, and they're on life support. And it's like, why? Because things didn't go well during the surgery. So people want to be cheap ass with their health. They don't want to pay money to get high quality care, and they think that they're saving money by going to where their insurance company wants them to go. But they're not. You see, when I fix a patient, they go home the same day and they go back to work within a day or two. They're back to work within a day or two. They're living a normal life. But when your surgeon does things in the surgery that compromise your life by injuring a blood vessel or a nerve, and you're on life support as a result of that, you see, here's where I differ from every other surgeon. I don't believe patients should run the risk of being on life support or dying from surgery of their spine to fix a herniated disc. But the other surgeons think that's acceptable. That's acceptable risk. So it doesn't bother them that a patient would die during elective back surgery for a herniated disc. But see, I could never live with that. And I've never in 22 years killed a patient or caused any serious injury to the patient that would put him in the ICU. Sure, once in a while you get a patient with a blood clot in the ankle. You know, it's uncontrollable. You do everything you can to prevent it. And that is a life-threatening condition. And they go to the emergency room and they get put on blood thinners for 6 months. And it is a big deal. But it's not the same as cutting the artery that goes to their leg and they have to have their leg amputated because you made a mistake in surgery. It's not the same as cutting a nerve and causing permanent nerve damage like I see happen all the time. It's not the same as killing the patient because you stress their heart or lung so bad because you take too long to do your surgery. These things happen every day. They happen every day. They happen all around the world. And it is wrong, in my opinion, for them to happen. That's why I do these broadcasts. I want people to see that spine surgery can be done safely, effectively, and people can go home. And they can be with their families, they can live their lives, and they don't have to worry about dying or being paralyzed from surgery. But that's not true for every surgeon. So, yeah, if your life matters to you, then invest in it. Do what needs to be done to be fixed, to be healthy, to be taken care of properly. So, the surgeries that people want are effective, durable, meaning they last their lifetime, safe, meaning they know they're going to wake up and they're going to be better than they were when they went to sleep. Okay? And that's very important. And a lot of doctors don't talk about that because they can't tell their patients that they're going to wake up and be safe, because maybe 10, 20% of the time they're not going to wake up with those other surgeons. Okay? But that's something you as a consumer, you as a patient, you as a potential victim should be thinking about. In my opinion, maybe you don't care. But if you don't care, then don't listen to my broadcast. Go do something else. Go watch Bonanza or something. But don't be here listening, pretending you care when you really don't care. This broadcast is for people who care. I'm not going to waste my time educating people who don't care. I want to spend my time educating people who want to make a difference. Whether they want to go out and they want to be active politically and fix the broken system that we live in so it can be better for patients, not just with spine surgery, but with everything. Or whether they want to help somebody who's in pain get out of pain so they can have a normal life. Okay? And the last variable is return to work, return to a normal life. There's no surgery of the spine in the world better than the Deuk laser disc repair getting people back to a normal life. You've all seen the 7mm incision. These people walk out of here an hour after their surgery is over. They walk out of here. They go home. And by tomorrow, they're back to a normal life with some minor restrictions. Okay? So, on all counts, effectiveness, durability, safety, recovery, and return to normal function, the Deuk laser disc repair, this endoscopic surgery you watched, is the best in the world. And I can tell you that because I know what every surgeon does, because I'm very, very, very good at what I do. And I know how to perform every surgery that every surgeon does. And I've performed it, and I'm perfectly capable of performing it. Okay? But I don't perform them because they're not nearly as good as this procedure. I perform this procedure because this truly is the best procedure for patients. And that's what I believe is right, is to always do what's best for your patient as a doctor. And I don't have to convince people. I mean, people know. And anybody who comes to me as a patient knows that I give them an option. I'll tell you can have a fusion, you can have artificial disc, you can have laser, endoscopic surgery. But people know, they're not stupid. They know what's best, and so they choose what's best when they can. They choose what's best. So I just want you all to be aware that there is a much better option out there. Whether you choose to do something about it or not is your choice. You have freedom of choice. But don't let an insurance company tell you what is best for you. You decide what's best for you and make it happen. And understand the stakes. Understand it's your life that you're putting on the line when you go cheap on spine surgery. I think that's all we have. Do we have any other questions? I want to say thank you to my team for being here tonight till late. And 6:30 is late for us, by the way. We're getting old. And I want to say thank you to Sean, who's sitting next to me, who's manned the comms all day and has done a great job. And we miss Zach because Zach left us and went to Utah, but he still works for us. So we love Zach out there. A big shout out to Zach, who built our Deuk Spine Institute app, which you should all download and use. I think you'll really like it. It's free, and people like free. So have a good night. Happy holidays if I don't talk to you again. And we should have surgery next week on Tuesday. God bless you.